Okay, so today we're going to discuss about embryology. Mainly, we'll focus on exam question related part because embryology is very vast, but we will discuss and focus only the exam related part. Okay, pharyngeal pouches mainly they develop during fourth week of gastrointestinal life, and they give derivatives of different organs. From the exam point of view, we have to remember at which week pharyngeal arches develop. So answer is pharyngeal arches develop during fourth week of embryonic life. Fourth week. Okay. And how many pouches are there? Total six pharyngeal arches are there. Sorry, arch. Total six pharyngeal arches are there. From first arch, remember this T and M. So from first arch, T and M. T, T and M. What are the T? T for tensor tympani, tensor veli palatine. These two muscles. T for these two. Tensor palatine and tensor tympani. These two. And M for muscle. Muscle of mastication. Then mylohyoid. These two M. Okay. So muscle of mastication, anterior belly of digestic, and mylohyoid. These muscles are tensor T, tensor tympani, and tensor veli palatine. Then again M with the M, maxilla, then malleus, Meckel's cartilage. Okay, these skeletal contribution comes from the first arches. There is no endocrine nothing, and the artery we have again M, maxillary artery and external carotid artery. This maxillary artery and the maxillary artery is the branch of external carotid artery, right? So these both are coming from first. And the nerve, which one? This is mandibular division of the trigeminal nerve. Mandibular division of trigeminal nerve, we can call it like B3, B3 of 5. Then second, from the second arch we have a BP. First we remember TM, and in the second we can remember S for S and SBP or systolic BP. B for Buccinator, okay. Then P platysma, posterior belly of digestive and stapedius. Then again S for stapes, styloid, and laser horn of the body of the hyoid. Not very important, but you have to remember the stapes bone. Sometimes they give the question stapes developed from which arch? From second arch. And which nerve? Seventh facial nerve. Seventh. Then number third, you can consider it as like third year of the medical school. From the third, T for thymus, T for T, third T for T, thymus and inferior parathyroid. This is important. This is exam question. They give either superior parathyroid or inferior parathyroid. Inferior parathyroid develops from third, and superior comes after this level. So third level they start with the inferior, and the fourth they develop from the fourth. Superior parathyroid develop from the fourth. Also, the nerve, mainly the nerve from the third, there will be glossopharyngeal on number 9, and from the fourth, vagus, superior laryngeal. Vagus and superior laryngeal, these two. Now, inferior laryngeal or recurrent laryngeal, you can say recurrent laryngeal, it will develop from 6. There is no 5. There is no 5 because this fifth arch actually fuses, and we have 6. From the 6, all intrinsic muscle of the larynx. This is exam question. All intrinsic muscle of the larynx except cricothyroid. You remember we discussed this one. All intrinsic muscle of the larynx or all extensive muscle of the tongue is supplied by You have to read that part. Tongue muscle and then nerve supply. Anyway, from the sixth pharyngeal arches, all intrinsic muscle of the larynx develops except cricothyroid. Because cricothyroid it develops from the fifth. So this is also exam question. Cricothyroid developed from where? Just 1 minute. Finish. Cricothyroid developed from fourth, and nerve comes vagus nerve, and recurrent laryngeal nerve. So this is all. In summary, if we go for summary, from the first arch we get B3 of fifth trigeminal nerve, then second facial nerve from seventh, glossopharyngeal from third, and vagus from both fourth and sixth. If I ask you thymus developed from which? Thymus, thymus T for T, T for T, thymus T for T, T for third. Okay, third, yeah. Now tracheopharyngeal anomalies. Just one second. You can read this part. I have one patient, just I'm finishing this one. By this time you can read this part. Just read. Yes, brother. What happened? Yeah, good. Lay. What happened? Oh, since how many days this is? 2 months. And there is no pain. See, my brother, very simple. If there was pain, doctor becomes happy. Pain means infection, and we can treat infection by giving antibiotic. Even if there is pus, we can cut and we can remove. But if you have a tumor and there is no pain, then doctor becomes afraid because we don't know what is this. It can be any growth. Okay. So our next step will be first we have to do an scan. Actually, we need to go for biopsy. Okay, if it was a big hospital, then doctor will recommend you to go for an biopsy. But from this level, I can tell you can go for an ultrasound scan first. Then at least they will give some information. What is there? Either it is a pus collection, fluid collection. Definitely there is no fluid, there is no pus, and this is a hard mass. Okay. Mm. Hopefully, hopefully. Your name? Name? Cristiano Ronaldo? Okay. How old are you? Only. Okay. I have written this ultrasound scan. You can ask in the reception. They will guide you. Okay. They will guide you. You can go to the reception. Okay. So now we are in Tracheoesophageal anomalies. You understood? Can you explain what is that? Mm-hmm. Mm-hmm. Okay. Okay. So esophageal atresia, which distal tracheoesophageal fistula, will be the most common, 85% cases. Okay. You can see the picture. What actually happens? This is normal trachea. We know the alignment, right? We have seen before about their position. Okay. Sometimes there is some atresia or narrowing or the constriction in esophagus. Sometimes, so this is also one kind of, this is normal, and this is one anomaly where there is a constriction over the esophagus, and this is also an anomaly where esophagus is constricted and it is connected with the trachea. And there is another anomaly here. This esophagus connection starts from the trachea and lower end of the esophagus is totally fused. Okay. Cleft lip and cleft palate. From here, they will give which of the following statement is false or true. Okay. So, cleft lip and cleft palate combined, they remains as 45%. Combined cleft lip and cleft palate will be 45%, and only cleft palate 40%. Two things. One is cleft palate. You have idea about this two, right? One is cleft palate. You can see this is cleft palate. Palate. Here there will be a gap between two sides. Normally during embryonic life they remain separate and they fuse together. Okay, but if there is any anomaly, then they will not fuse and there will be gap. Okay, this is one, and this is cleft lip. Lip also, right side and left side, they both develop separately and then they come and fuse together in the midline. But if there is any anomaly, then there will be a gap. Sometimes patient might have only cleft lip, sometimes they might have only cleft palate, sometimes they might have both cleft lip and cleft palate both. That's why cleft lip occurs as a result of disruption of the mucus of the upper lip and nasolabial region. Up- Disruption of the muscles of the upper lip and the nasolabial region. Okay, only this much you have to remember. It occurs as a result of disruption of the muscles of the upper lip and the nasolabial, upper lip and the nasolabial region. Okay. Cleft palate occurs as a result of non-fusion of the two palatine shells. This is exam question. Okay. Cleft palate, two palatine shells, right and left. They both come and fuse together. Both palatine shells. But if there is any uh, abnormality, then palatine shells will remain apart, and this is cleft palate. And the treatment, surgical reconstruction, is the mainstream of the management. Okay, so treatment of the cleft lip, cleft palate will be surgical correction. Conal atresia. Conal atresia also, see, it is not very common. It happens 1 in 7,000 births. Okay, posterior nasal airway occluded by soft tissue or bone. Normally, when our nostril, nostril is open, but sometimes there could be soft palate in the posterior aspect of the nostril or the bone. So the nose will be blocked. Okay. And babies with unilateral disease may go unnoticed because suppose this is our nostril. Okay. This is our nostril. This too. And normally it remains open because ear from there goes inside and then it connects with our pharynx. Right. Sometimes soft palate. Here will be the soft palate. Soft palate grows or there will be bony structure which blocks one side. If it is one side, then from another side, suppose right side it is blocked, left side open. So from the left side, the child can continue breathing. Okay, mostly it happens. These are the congenital anomalies. I mean, um, these whatever the disease or anomalies we are discussing, these all will be diagnosed in an infant. This is not the adult disease, right? So normally both nostril will be open. If there is any one side blocked, child will be able to continue breathing. It will be not noticed. But with bilateral, they will present early in the life. They can then only breathe through the mouth. Okay, because nose is blocked. They cannot breathe. It is kind of like in the common cold. When nose is blocked and they continue breathing with the mouth, it is also that type of treatment with the fenestration process designed to restore patency. So fenestration procedure, this is the exam question. Conal atresia treatment, fenestration procedure. Actually, they make a communication, so it is easy, right? So what part we need to remember? Conal atresia, it happens due to airway occlusion by either soft tissue or the bone associated with, this is also question. Conal atresia associated with which congenital anomaly? This is coloboma. Coloboma. Conal atresia associated with other congenital malformation that is called coloboma. And if it is bilateral, child used to take breath through the mouth. And if it is one lateral, it may remain undiagnosed. Treatment will be fenestration procedure. Okay. Meckel's diverticulum. Meckel's diverticulum. This is Meckel's diverticulum. This is the guard, and here there will be a projection like this. This is Meckel's diverticulum. Okay. And this is the exam question. Meckel's diverticulum. They follow rule of two. Okay, Meckel's diverticulum, they follow rule of two. What is rule of two? It is two times likely in males. Meckel's diverticulum mostly happens. Meckel's diverticulum, when we do laparoscopic procedure like appendectomy, then we explore to look out if there is any Meckel's diverticulum or not. Okay, what is Meckel's diverticulum? Actually, this is the persistence of vitelline duct that that maintains communication with the umbilicus and the gut, but normally it obliterates. Okay, normally it should go back to normal. I mean, there should not, because when we cut the umbilical cord, there will be no circulation, and it mm, disappear. But in some cases, it may persist. In umbilical cord, here, okay, umbilical cord we have seen before. In umbilical cord, how many arteries will be there? Two umbilical artery. And how many vein? One umbilical vein. So during fetal life, our venous circulation is more, but normally in adult after birth, our arterial circulation is more. But in intrauterine life, venous circulation is more. Okay, you can see two umbilical artery and one umbilical vein. Fetal circulation, fetal circulation three shunt. One is ductus venosus, closure within 5 days. Then foramen ovale and ductus arteriosus, closes within 10 days. You have to remember this point. Ductus venosus vein closes in 5 days, and arteriosus, or it is artery, it closes in 10 days. Simply, artery is more thicker. It takes more days to obliterate. Okay, so it closes within 10 days. Ductus arteriosus, ductus venosus closes within 5 days. Now changes at umbilical vein. Yeah, this is important. Umbilical vein, umbilical vein becomes ligamentum teres. You remember ligamentum teres, where we studied ligamentum teres in liver. In liver, we got ligamentum teres when we were studying about what the yes this come yeah this come. You just read this part ligamentum teres, then ductus venosus. Ductus venosus will be ligamentum venosus, foramen ovale, fossa ovale, and ductus arteriosus, ligamentum arteriosum, left recurrent laryngeal veins around it. Okay, this is important. Now, just read this rule of twos. This is exam question. Rule of twos. Just read. Yes, madam. What happened? I'm fine. What happened? Some discharge coming. Mhm. Can you? No, you. No, no. You consulted with any doctor here? Did you consult with any other doctor here? Can you remain this open this one? Mm-hmm. Brother, you need to go to a ENT specialist. Okay. I will write. You can put it back. I can put it back. I'm writing for you. No, you can cover it again. His name, Davy. Hmm. Age. You can show this paper to reception. They will guide you. Okay. Okay. Yeah, reception. Okay. So what is rule of two? We are talking about Meckel's diverticulum. It happens mostly in males, two times in males, and 2 inch long, 2 feet from the ileocecal valve, and it happens in 2% of the population, commonly present in the first 2 years of the life, and may have two types of epithelial, gastric and pancreatic. Very nice. Can you say some of this? What is rule of two? Congenital heart disease. Congenital heart disease. Here we need to check. Okay. Mhm. So congenital heart disease, cyanotic and acyanotic. Mainly exam question comes from here in this pattern, that cyanotic or acyanotic. So acyanotic, ventricular septal defect (VSD), and this is the most common, and accounts for 30%. Okay, and this is VSD, ventricular septal defect. You have idea, right? This about this. Just you know, common concept. No need to go in details. Ventricular septal defect (VSD) 30%. Then atrial septal defect, patent ductus arteriosus, coarctation of the aorta, and aortic valve stenosis. So uh, these are acyanotic, and these are most common causes. And ventricular septal defects are the more common than atrial septal defect. And cyanotic, most common causes: tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, pulmonary valve stenosis. 4. Cyanotic will be tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, and pulmonary valve stenosis. Right to left shunt. This is right side, this is left side. If there is right to left shunt, okay, then early cyanosis, blue babies. Sometimes this is the clue. Blue babies, you remember, this is right to left shunt, right to left shunt, blue babies. No need in detail. These are very interesting topic, I know. So everyone feels very concentration while studying this topic. TOF, you have to remember four options: TOF or tetralogy of Fallot. Most common cause of cyanotic congenital heart disease, typically present around first 2 months, and although it may not be picked up until the baby is 6 months old, maybe. What will be the feature? This is important. Tetralogy of Fallot. What are the four component will be there in tetralogy of Fallot? First, ventricular septal defect. This is atrium and ventricle. So here there will be a defect. Unfortunately, I cannot in this picture. Okay, okay, good. So ventricular septal defect, right ventricular hypertrophy. Okay. Ventricular septal defect here, then right ventricular hypertrophy, this one, then right ventricular outflow obstruction here, there will be pulmonary stenosis and overreading of the aorta here, overreading of the aorta. Four components. Can you repeat what are the components of top? Yes. Other features: child will have cyanosis, causes right to left shunt, and ejection systolic murmur. Ejection systolic murmur due to pulmonary stenosis. Hmm. Which type of murmur? Ejection systolic murmur due to pulmonary stenosis. A right-sided aortic arch is seen in 25% of the population. Chest X-ray shows a boot-shaped. This is exam question clue. They will X-ray shows boot-shaped heart, and ECG shows right ventricular hypertrophy, and child is cyanotic, and on auscultation you got ejection systolic murmur. So this is clearly taught. This is the X-ray picture. You see, it looks like a boot. It looks like a boot. Tetralogy of Fallot. Okay. Portion of the aorta. মানে- हेलो मैं जिंदा हूँ, आप कैसे? हाँ, ले लीजिए. Okay. Now ventricular. Mhm. Ventricular septal defect. Most common cause of congenital heart disease, and it occurs around 50% cases. Classically as a pan-systolic murmur, and previous on top was ejection systolic murmur, right? It was ejection systolic murmur. That means we can auscultate murmur only during ejection, and this is pan-systolic. Pan-systolic means whole throughout the systole will get murmur. Classically, a pan-systolic murmur which is louder in smaller defect. Yes. And complication: aortic regurgitation, infective endocarditis, Eschen-Menger's complex, and right heart failure. If exam question becomes difficult, then you will get questions from here. Normally, from embryology, question comes from the arches and pouches. Those are very common questions. But if they want to make question little harder, they will come these topics. But of course, within this, they will not go beyond this. Okay. Ventricular septal defect. This is this is an MRCS Part B also. Okay. This is diaphragm. Okay. In diaphragm, there could be some abnormalities like Bogdalek hernia. See here, this is the defect. In here, this is the defect. Here, this is the defect. This is central hernia. This is marginal hernia. Okay. Bogdalek hernia. Okay. Bogdalek hernia, bad effect. Bogdalek hernia. I think you got some question from Bogdalek hernia while reading. Remember? How come? Bogdalek hernia, there must be. Okay, Bogdalek hernia is something. There will be, see, here is a big defect, a very big defect, Bogdalek hernia. Okay, that's why what happens, part of the stomach or part of bowel, it goes in the chest. Okay, that's why bowel sound will be there in the chest, and abdomen will be scaphoid. This is the exam clue. Scaphoid abdomen, and on auscultation, you found bowel sound on the chest. Blindly you can answer this is Bogdalek hernia. Okay, and normally it remains asymptomatic, an incidental finding. Maybe child is not having any came with fever or cough. So you are just auscultating the chest. While auscultating the chest, you are getting bowel sound. Also, abdomen is scaphoid shape. Abdomen will be like this, scaphoid, and child will be cyanosed, dyspneic. This is exam question. Why it happens? Failure of obliteration of the pleuroperitoneal canal. Failure to develop of the pleuroperitoneal fold. Bogdelic hernia develops due to failure of the pleuroperitoneal fold. Pleuroperitoneal fold. Pleuroperitoneal canal. Failure to develop of the pleuroperitoneal fold. Bogdelic hernia develops due to failure of the pleuroperitoneal fold. Okay. Septum transversum. Pancreas and spleen. While discussing abdomen, we have gone through in details about the pancreas and development. Just remember, pancreas develops from foregut. You remember foregut, midgut, hindgut. Foregut extends from where to where, midgut from where to where. So pancreas, it comes with the upper or the first one. It develops from the foregut, and the ventral pancreas bud contribute unfinished process and main pancreatic duct. Annular pancreas, yes. Ventral pancreatic bud abnormally encircles second part of the duodenum, forms a ring of the pancreatic tissue that may cause duodenal narrowing and patient constipating. This is second part of the duodenum, and this pancreas, if it encircle like this, then there will be a narrowing or constriction. Spleen arises in mesentery of the stomach but has foregut supply from celiac trunk by celiac artery. I'm sure you remember um, blood supply of stomach. Hirschsprung disease. Hirschsprung disease. This is a congenital megacolon. You can see colon became very large, very large. Congenital megacolon characterized by lack of ganglionic cells, which plexus, Auerbach's and Meissner's plexus in the distal segment of the colon. As a result, the colon becomes very big, and present with bilious emesis, abdominal distension, and failure to pass meconium with 48 hours. Hirschsprung disease. Again, this is a congenital megacolon. Why it happens? Because of some nervous system abnormality, mainly the Auerbach's and Meissner's plexus abnormality in the distal segment of the colon. As a result, child will come with abdominal distension and emesis, vomiting, because child will take feeding, but because of this abnormality, there will be no passes of stool. And um, yeah, treatment will be surgical correction. Diagnosed by absence of ganglionic cell on the rectal suction biopsy. It is confirmed by rectal biopsy. There will be absence of ganglionic cell, and treatment will be resection. Very unfortunate. Thyroid development. No, important. Important. Okay. This is thyroid gland. Unfortunately, my pen not working here. Thyroid gland, and there will be a thyroid pyramid, or like another lobe. We know thyroid has right lobe, left lobe, and isthmus, but there could be another lobe which connects the upper. See, mm, thyroid diverticulum arises from the floor of the primitive pharynx and connected to the tongue by thyroglossal duct. This is thyroglossal duct, thyroglossal duct, and this is foramen cecum, foramen cecum. Okay, foramen cecum is normally remnant of the thyroglossal duct. This is exam question. Which of the following is the remnant of thyroglossal duct? Foramen cecum. Gastrochiasis, exomphalos. We discussed this before also. Gastrochiasis is some abnormality. I mean, viscera will be out of the abdomen through the umbilicus, right to the umbilicus. Okay, this is kind of herniation of the abdominal content right to the umbilicus. Bowel lies outside abdominal wall through defect located in the right to the umbilicus. This is gastrochiasis. And another one, if it comes through the umbilicus, then it is exomphalus or omphalus. If it is at the side of the umbilicus, right to the umbilicus, gastrochiasis, and if it is through the umbilicus, this is exomphalus. It has two varieties, minor and major. If the defect size is less than 5 centimeter, it is called minor exomphalus. If the defect is more than 5 centimeter, it is major exomphalus. Like this. This is umbilicus, and it is coming right to the umbilicus, right to the umbilicus. So this one is gastrochiasis, and there will be no covering. Okay, and if it comes through the umbilicus, then it will be exomphalus. It has two, minor and major. Liver, pancreas. Here they have written in very short. Okay, septum, transversus, ventral mesentery, gallbladder, ventricular outportion. Okay, pancreas, outgrowth of hepatic diverticulum. It has two buds, ventral bud and dorsal bud. B for B and D for D, I said. Okay, dorsal bud, minor papilla, ventral bud, major papilla, and uncinate process. These are okay. urogenital plexus, foregut, mandate, hindgut. If you read this, NPS already we have seen. Pronephros, mesonephros, mesonephric duct. Okay, come to kidney. Kidney develops from intraembryonic intermediate mesoderm. Kidney develops from, you can remember, kidney develops from mesoderm. Okay. Now from which part? See, uh, pronephros regresses early, non-functional. Mesonephros functional, regresses, and metanephros definite kidney. This is development of kidney during embryonic life. From which part of mesoderm kidney which part? Because kidney whole it's a system like renal system. So kidney, ureter, urinary bladder. From where it develops, you have to remember. Kidney, simple. In simple, you remember kidney develops from mesoderm. Okay, from metanephros, or ureteric part of metanephros. Urogenital system. This one also intraembryonic intermediate mesoderm and gonadal part of urogenital bridge. Germ cell originate from epiblast. These all are single question. Germ cell develops from epiblast. In case of male, from mesonephric duct, vas deferens, epididymis, seminal vesicle they develop. Paramesonephric duct, ejaculatory duct. Leydig cell comes from mesonephric mesenchyme. Sertoli cell from sex cord. Governiculum guide descent of the testis. This is exam question. Which of the following guide descent of the testis? Governiculum guide descent of the testis. Okay. Genital tuber. I mean that not governiculum guide descent of testis. Yeah. Testis remains into the abdomen and with the time it descends, and governiculum is the part which guide the testis to follow. Okay. And penis develops from urogenital fold. Scrotum from labioscrotal swelling or fold. In case of female, fallopian tube, uterus and top of the vagina is developed from paramesonephric duct. Fallopian tube with uterus and upper part of the vagina, it comes from paramesonephric duct. Round ligament of the ovary and the uterus develops from governiculum. In case of female, governiculum. In case of female, round ligament of the ovary and the uterus. And genital tubercle, it gives organ to clitoris, corpus cavernosa and bulbo spinosum. Okay. Just remember this important part. Here is a summary. Summary all explained together. Hernia, direct, indirect. Direct hernia due to an acquired weakness in the transversalis fascia. Increased incidence with the age, COPD patient, hernia protrudes directly through the weakness, that is Hasselbalch triangle, without traversing through the inguinal canal. Remember Hasselbalch triangle? Can you tell me the boundary of Hasselbalch triangle? Yeah, can you tell me the boundary of Hasselbalch triangle? Okay, okay, very good. Yes, you remember exactly. Good. So Hasselbalch triangle, you know, Hasselbalch triangle. This is rectus abdominis. This is pubic tubercle, rectus abdominis here, lateral margin of rectus abdominis, and here will be the what? Inguinal ligament, and here inferior epigastric vessel, inferior epigastric vessel. So this is rectus abdominis, inguinal ligament, and inferior epigastric vessel. This is Hasselbalch triangle. If any herniation happens through this area, this will be direct. But if it happens through the inguinal canal, inguinal canal, then it will be indirect. Why indirect hernia happens? Because of due to patent processus vaginalis. It is a congenital defect which follows for the hernia of the to the traverse of the inguinal canal and superficial inguinal teeth. Simply, indirect inguinal hernia happens due to processus vaginalis. It is a congenital defect. This is so indirect hernia considered as like the congenital defect because of the presence of processus vaginalis. But direct hernia is acquired. It happens due to increased workload, maybe heavy weight lifter or chronic cough like COPD patient. Okay, cryptorchidism, congenital undescended testes is one of the one that has failed to reach the bottom of the scrotum by third month of age. Okay, at birth, 5% of the boys will have a undescended testis. Postnatal, descent occurs in the most, and by 3 months, the incidence of cryptorchidism falls by 1 to 2%. Okay, so during birth, 5% of the boy might have testes, even in the inguinal canal or in the upper part. But usually descent completes after 3 months of birth, and 1 to 2% they might not completed their journey. Patent processes vaginalis, abnormal epididymis, cerebral palsy, mental retardation, Wilms tumor, and abdominal wall defects. Okay. Okay. If the examination clinician notes that the testes is retrieved rapidly into the inguinal canal when released in surgery is probably indicated. Reasons for correction of the cryptorchidism because reduces the risk of infertility. Okay, allows the testis to be examined by testicular cancer. Okay, avoid testicular torsion. Okay, male with undescended testes are 40 times likely to develop testicular cancer, which is seminoma. Very unfortunate. So those who don't have, I mean, those who have undescended testes means their testes remain inside the abdomen, and 40% of them they develop cancer, testicular cancer. That's why it is better to do surgery and remove. Okay, as means without undescended testes. The location of the undescended testes affects the relative risk of testicular cancer 50%. Abdominal testes. Hmm. Treatment for orchidopraxy at 6 to 18 months of the age. Operation will be inguinal exploration. Surgeon will find out where the testis is located, then mobilize of the testis and implantation it in darto pouch. In dartos pouch. Intra-abdominal testis should be evaluated laparoscopically and mobilized. After the age of 2, After the age of 2 years, in untreated individuals, the Sertoli cells will degrade, and those presenting late in teenage years may be better saved by orchidectomy than than to try and salvage non-functioning testes with an increased risk of malignancy. Okay. It could be retractile, ectopic, or undescended testes. Ectopic testes, from here you will get the question more. Ectopic testes and undescended testes. Mhm. Okay.
तो डॉक्टर ने नोट्स भेजा कि हमारे पास डॉक्टर है और कंप्लीमेंटेशन तो आप ये लेके डॉक्टर ने उसको भी बता दिया कि सर के पास जाओ और चेक कर लें अभी ये मेडिसिन इसके पाकिस्तान से ये ट्रीटमेंट इसका स्टार्ट है
हम वो करते हैं अगर एलोपेशिया एरिया का स्पेसिफिक जगह पर ऐसा ये तो ओवरऑल उनका हार्मोन भी थोड़ा रीजन क्या है
वो ये ट्रीटमेंट ले रहे हैं जैसे स्किन ट्रीटमेंट ले रहे हैं पाकिस्तानी ट्रीटमेंट है
इसमें कोई फर्क आ रहा है आपको आपको लग रहा है कि ये बाल पहले से थोड़ा ज्यादा हो रहा है तो ये स्टेरॉइड भी अगर आपका उम्र अभी बहुत छोटा है ठीक है उम्र 20-25 होता होगा स्टेरॉइड का बहुत साइड इफेक्ट होता है ठीक है सिंपल बात देखिए अगर आप बाल के बगैर भी पूरा जिंदगी जी सकते हैं कोई मुश्किल नहीं होगा ईयर इम्प्लांट भी है पर अगर जिंदगी भर आप ऐसे स्टेरॉइड लेते रहे तो बहुत तकलीफ आएगा सामने में आपका बच्चे पैदा होने में या सब कुछ में ये मुश्किल होता है ये अच्छा है ये शैम्पू एंटी डैंड्रफ और सेवरिक डर्मेटाइटिस ये दवाई हम भी लिखते हैं ये मेरा एक फेवरेट दवाई के पास पर ये सिर्फ 5 दिन के लिए मिथोट्रिक्सेट मैं बताएंगे अच्छा रहेगा आप एक डर्मेटोलॉजिस्ट को दिखाइएगा उसकी स्पेशल ठीक है
ये भी डॉक्टर ने दिया
इधर थोड़ा दिखाइए आप ये शैम्पू इस्तेमाल कर सकते हैं कोई मुश्किल नहीं और मेरा रिक्वेस्ट है कि ये सिर्फ 5 दिन के लिए उसके बाद बंद करना है ठीक है
सही है ना Idea of suggestion doesn't surround a
Okay. So ectopic. Walaikum salam. How are you? Yeah, I remember. Yes, it's okay. But I remember you. How is the condition now? Mhm. You have last prescription, previous prescription. Okay, malum. আমি আপনাকে দেখেই চিনতে পেরেছি এবং আপনার কোমরে ব্যথা ছিল যেটাকে আমি সায়াটিকা বলেছিলাম।
لقد تعرفت عليك وكنت تعاني من ألم في ظهر أثناء أسبوعك الماضية.
আপনাকে আমি ব্যবহার করার জন্য কোমরের বেল্ট দিয়েছিলাম এবং কিছু ফিজিওথেরাপি এক্সারসাইজ করার জন্য বলে দিয়েছিলাম। আপনি কি সেগুলো নিয়মিত করছেন?
أعطيتك حزاما للفصل
Why?
وطلبت
এই দাবাই
منك قياما ببعض تمارين العلاج الطبيعي. هل تقوم بها بانتظام؟
আপনার ব্যথা কমার জন্য এখন আমি কিছু ইনজেকশন দিব এবং একইভাবে আরো কিছু ওষুধ লিখে দিব। কিন্তু আপনার এই চিকিৎসার আরো উন্নতি হওয়ার জন্য আপনাকে অবশ্যই ফিজিওথেরাপি নিতে হবে এবং কোমরের বেল্ট ব্যবহার করতে হবে।
سأعطيك الآن بعض الحقن لتخفيف الألم وسأصف لك بعض الأدوية الأخرى أيضا، ولكن لكي يتحسن هذا العلاج أكثر يجب أن تخضع للعلاج الطبيعي وأن تستخدم حزام القلب.
ওকে,
دكتور دواء نو فايدة
দাওয়া লাজিম,
لازم
দাওয়া লাজিম। Name?
محمد
Omar, age?
تمام
Omar?
44 45
You are from which country?
no never
Lebanon. How is your family? Good, all good?
دكتور هذا علاج طبيعي علاج طبيعي وين عنده العلاج؟
center, physiotherapy center, like any hospital, NMC or Esther or Burjil. Zendul.
صديق بدل صديق my friend سمسم سوي علاج طبيعي سوي نكبة جديدة سمسم نفسه أنا هذا طرف هو هذا طرف سمسم ما في فايدة 0% ما في فايدة
Physiotherapy?
أيوه 0% ما في فايدة
আসলে সায়াটিকা যদি একটা লিমিটের মধ্যে থাকে তাহলে ফিজিওথেরাপির মাধ্যমে রোগী উপকৃত হতে পারে, কিন্তু এটা যদি কম্প্রেশন অনেক বেশি হয় তখন আসলে ফিজিওথেরাপিতে খুব একটা উপকার হয় না। সায়াটিকার পাশাপাশি অনেক সময় প্রোলাপস ডিস্ক হয়, মানে আমাদের যে মেরুদণ্ড থাকে, মেরুদণ্ডের মাঝখানে হাড়ের মাঝখানে যে একটা ডিস্ক থাকে, ওই ডিস্ক আমাদের নার্ভের উপরে চাপ দেয়, এই কারণে ব্যথাটা হয়। আপনি এখন এই ইনজেকশন গ্রহণ করুন এবং বাকি ওষুধগুলো খাওয়া শুরু করেন। আপনি কমপক্ষে 5 দিন পরে আবার আমার কাছে আসবেন, কারণ আপনি আমার কাছে শেষবার এসেছিলেন কমপক্ষে 2 থেকে 3 মাস আগে, তাই এই মাঝখানে কি হয়েছিল আমি জানি না। আমি এখন বলবো যে আপনি 5 দিন পরে আবার আসুন।
في الواقع إذا كان عرض المكان محدودا فيمكن علاج المريض بالعلاج الطبيعي، أما إذا كان الضغط شديدا فإن العلاج الطبيعي يعد خيارا ممتازا. إضافة إلى ذلك قد يعني التوتر والوكيل أحيانا أن الفرصة الموجودة في منتصف العمود الفقري في منتصف الفقري يضغط على الأعصاب، وهذا هو عليك أخذ هذه الحكمة الآن والأدوية. ستعود إلي بعد 5 أيام على الأقل، لأنك زرتني في المرة السابقة.
আপনি এখন অবশ্যই কোমরের সাপোর্ট বেল্ট কিনে নিয়ে যাবেন এবং এটি ব্যবহার করবেন, বিশেষ করে আপনি যখন গাড়ি চালান এবং যখন কোনো ভারী জিনিস উঁচু করেন।
الآن بالتأكيد اشتريت جام دعم أسفل الظهر واستخدمته، خاصة عند قيادة وعند رفع الأشياء الثقيلة.
دكتور أنا
Thank you, thank you, thank you, thank you. Now you can start this one. I'm very happy. আপনার কমেন্ট শুনে আমি আসলেই অত্যন্ত খুশি হয়েছি এবং আমিও চাই যে আপনার এই অসুখ সম্পূর্ণ ভালো হয়ে যায়, এবং আমি আপনাকে আশ্বস্ত করে বলছি, পূর্বে আমি আপনার মতো অনেক রোগীকে চিকিৎসা করেছি এবং যারা আমার পরামর্শ অনুযায়ী চিকিৎসা নিয়েছে তারা সবাই উপকৃত হয়েছে। আমি আশা করি আপনিও উপকৃত হবেন।
وصلوا للحقن معي تعليق جدا، وأتمنى أن يشوفوا أرقامنا من عيادتك، وأؤكد لك أنني عالجت العديد من المرضى متكفلين
شكرا.
والذين اطلعوا
Yes, thank you.
قبل نصيحتي قد شفوا كما.
Okay, we will continue. Ectopic pregnancy and undescended testis, two different things. Undescended testis is something. Yes, I'm sorry. Sorry. Ectopic testis is something. It is undescended testis. This is the root. This is the way of descent. Okay. Through this way, testis will come to up to the bottom of the scrotum. This is the normal way. But if testis remain any other place apart from this normal pathway, then it will be ectopic. Okay. Suppose it may remain in the root of the penis, in the high, okay, and superficial inguinal canal, superficial inguinal ring, exiting the superficial inguinal ring, like superficial inguinal pouch, perineum, root of the penis, then these will be the ectopic testis. Spina bifida. This is body of the vertebra and remaining part is the spine. Here will be the inguinal. This is neural foramen or vertebral foramen. Okay, like this you can see here. Here, spinal cord will transmit through this area. This is body and all other part are the spine or the arches. Non-fusion of the vertebral arches during embryonic development causes spina bifida. Up to 10% of the population may have spina bifida occulta, may be identified by birthmark or hair pouch. Okay. Spondylolysis, very important. Question comes from here. Congenital or acquired deficiency of parts intra-articularis. Parts intra-articularis here. This is parts intra-articularis here in the picture. You can see parts intra-articularis absence causes spondylolysis. Okay. Usually it affects lumbar 4 and lumbar 5 region. Another term almost similar. This is spondylolisthesis. And in the X-ray picture will be Scotty dog. This is example clue. If you get this spondylolysis part sliding of, you can see the picture, sliding of one vertebra body over another, and it looks like a Scotty dog may occur as a result of stress fracture. This is either congenital or maybe a acquired deficiency, maybe due to a trauma. Okay. This one patient will have severe disc compression, I mean nerve compression, and patient may present the feature of paralysis depending on which level. Okay, mostly it happens also in the lower region, number 4, number 5, and symptoms of usually require spinal decompression and stabilization, mainly surgery. meningocele, myelomeningocele. These are the defect. Anencephaly. Mainly, spondylolysis occurs due to stress fracture in pars interarticularis. Just remember this feature. Spondylolysis stress fracture in the pars interarticularis. This is uh, pars interarticularis. This part. And spondylolisthesis, it also occurs due to stress fracture and sliding of the vertebra. Stress fracture and sliding of the vertebra. Okay. Talipes equinovarus, or this is called class foot. In my previous workplace in Maldives, we used to treat this. There will be serial casting. Okay. See, yeah, this is very easy and simple. But have to do serial casting. First, the child comes in this pattern. See the pattern of the foot. Then we apply plaster, and there will be mild correction. Then in the next setup, you see foot becoming normal, and now it became totally normal. That's why orthopedic has the beauty of work, and people will remember the whole life. Someone who cannot walk, if you can treat him correctly, suppose someone lost the limb, the leg after the accident, and you can put an artificial limb, then he will be able to walk again. So he is getting back his full life. Okay. Yeah, that is all.